I'm now going to turn over the microphone to Renee Quache, and we'll move to our second panel. Renee?
Yeah. Thank you, Dr. Hearn. Really appreciate it. As Dr. Hearn just said, I am Renee Quache. I am the Vice President of Digital Health at the Consumer Technology Association. Everybody, welcome to our panel, How Connectivity is Enhancing Health and Transforming Healthcare, Emerging Technologies and Innovations. We have a great panel today representing a number of sectors and perspectives, and I hope you find the next hour very interesting. It's a preliminary matter. As we all know, not all people in the United States have the same opportunities to pursue a healthy lifestyle. As Dr. Berwick just talked about, this is largely due to access barriers and social determinants of health. But I think it's fair to say we're in the midst of a transition. What do I mean? How healthcare is delivered and consumed is changing dramatically as technology advances. Many stakeholders, some of whom are going to be represented on this panel, developing and deploying innovative digital health tools for use everywhere, from hospitals to home. And this innovation has the potential, tremendous potential, I would argue, to better democratize healthcare in the United States. So we have tools ranging from artificial intelligence-driven clinical decision support to diagnose patients, to wearable technology, remote patient monitoring, telehealth, even to the use of digital therapeutics to tackle mental health and substance abuse issues. Healthcare is undergoing a significant digital transformation. The issue, and what brings us all here, is that much of this innovation works most effectively with high-speed connectivity. So in other words, if a person is not connected, that person is at risk of not being able to access the latest and high-quality care. Which brings us to this great panel. In terms of housekeeping items, how we're going to do this is I am going to have each of the panelists introduce themselves, their role in the organization, and the kind of work the organization is doing at the intersection of some of the issues we're talking about here. And then we'll get into some Q&A. If you have any questions as we're going, please include them in the Q&A portion of the platform, and we'll try to get to as many of them as possible. And so with that, we're going to start the introductions, and I'm going to turn it over to Dr. Karen Laban to get us started.
Thank you, Renee. And can you hear me? If you could just confirm, yes? Oh, good, perfect. Thank you. And thank you to the task force for organizing this day and for all the work that you have done for so very long. We are proud supporters and collaborators with the Federal Communications Commission and the work that you have been doing for many years now. So I'm the medical director of the telemedicine program at the University of Virginia. I'm a pediatric cardiologist and have had a long-standing career of traveling to see patients all over the Commonwealth of Virginia. And as such, about 25 years ago, we established our telemedicine program, which was designed to improve access to care for patients across the Commonwealth of Virginia. Prior to COVID-19, we partnered with more than 150 sites across Virginia and did some international work as well. And then did a strategic plan for telemedicine in 2019, right prior to COVID-19. And following that, we scaled massively. So I really look forward to the discussion in this session so we can talk about all the innovations that we and others have developed to bring care to patients where they are, and that has to be facilitated by broadband communication services. So thank you, Renee, for the introduction.
Great. Dr. Rue?
Yes, thank you, Renee. Thank you, everyone, for hosting this panel. My name is David Rue. I am the Global Chief Medical Officer for Microsoft. I'm a physician, technologist, health services researcher, spent the past 25 years looking at how technology can be used to improve access to care, quality of care, patient safety, improve the experience for both patients and providers, and also find ways that we can improve the efficiency of care. A big part of what we've explored over the past decade has been digital technologies that allow us to be able to provide care in the home, outside of the clinics. These are opportunities for us to be able to, as Dr. Berwick had said, rethink how care can be delivered. But at the same time, we've also seen that there are some challenges. The first and foremost, many of these individuals that we are trying to service don't have the capabilities to be able to take advantage of the digital technologies and the AI that we're developing. And so a big focus for us has been to start with the digital building blocks that allow for individuals across the country and the globe to be able to have those working in collaboration with local organizations through public-private partnerships. We launched the Airband initiative in 2017, have identified areas and opportunities for where affordable broadband may be applied, but there's a lot of work to be done. We expect that a lot of this work will continue in collaboration with the FCC and other organizations, and look forward to today's discussion.
Thank you, Dr. Rue. Michael Crawford.
Good afternoon, everyone. Thank you to the task force and FCC for hosting this timely and meaningful conversation. I am happy to be here this afternoon. My name is Michael Crawford. I'm the Associate Dean for Strategy, Outreach, and Innovation at Howard University College of Medicine, also the founding executive director for Howard University's 1867 Health Innovations Project. And I really want to focus my introductory comments on our innovation program. 1867 was founded in April 2020, but the conception and design was thought through prior to COVID-19. The program is designed to partner with entrepreneurs, researchers, corporate partners to tackle complex challenges confronting vulnerable and medically underserved communities from a digital health perspective. So we're really looking at 4 key areas. How do we increase access to technology? How do we improve healthcare outcomes with technology, the patient experience, as well as affordability? And at the heart of the work that we're doing, broadband is critically important. We have been hosting small pilots using technology either to augment existing models of care or looking at designing new models of care supported by technology to really think about how we improve health and well-being for the most vulnerable among us. And some of those lessons learned from our pilots have been broadband is an essential component in order for folks to be able to achieve optimal health. Digital literacy needs to be focused and concentrated on to make sure that everyone has the competence and confidence to optimize the use of technology. Also need to think about how we look at this bi-directional training component of patient/consumer with provider to make sure that everyone is operating from a robust understanding of digital literacy. So we've been doing a lot of great work in this space and really looking forward to diving a little bit deeper about our efforts as well as the way broadband can help improve the health and well-being for vulnerable communities.
Thanks, Michael. And as I initially said, we've got a very diverse set of perspectives here. We've heard from academic medical center, we've heard from Microsoft, and now we're going to hear from a telecommunications company. Joe, I wanted you to introduce yourself and some of the work you guys are doing.
Very good. Hey, thanks, Renee. Thanks for having me on. And I'm not a medical doctor, but I am a consumer and certainly an evangelist for the way connectivity and technology can transform the patient experience. And I know we've all experienced gaps and challenges. And so thank you to the FCC for having us and having this conversation today. At AT&T, we believe that connectivity will underpin transformation in healthcare. And we're on a mission to be the premier connectivity enabler for this kind of transformation. The last couple of years have been clearly very, very difficult and a lot of hardship, but there has been a few silver linings. And I think it's in this area. Many people have never had a virtual visit or had any kind of virtual care prior to the pandemic and experienced it during that period of time. And there have been some real benefits to it. First off, reimbursement's gotten a lot better. And so I think it started to open doors for what's possible for providers and consumers. But we still believe there are a couple of issues. One of them is connectivity and the lack of connectivity. Not everybody has access to the internet. And the other one is a lot of these technologies have been very difficult to use. So specifically in our healthcare practice, we're working on addressing those two things. And I have the pleasure of leading the healthcare vertical for AT&T, which is a vertical comprised of healthcare providers and the entire continuum of care, including a lot of startup technology as well. So really quickly, for connectivity, there's a couple things that we're doing at AT&T, and I can share a little bit more about it. The first being, we are the nation's provider for FirstNet, which was born out of the unfortunate situation at 9/11 when the first responders could not communicate because there was so much congestion on the network. 5 years ago, we won that award, and we've been deploying FirstNet. And through the pandemic, the FirstNet Authority approved virtual care as a use case by which we can use that network. So FirstNet provides differentiated connectivity, better reach into rural areas, and priority for those that are on the network. And many of the virtual care and remote patient monitoring solutions that we've worked to enable have been able to take advantage of this platform. The other thing, as Dr. Rue said, is that still a lot of people do not have internet access or broadband in the United States. 14.5 million Americans still lack access to internet. And so at AT&T, we've made a big investment through between 21 and 24. We've announced that we will invest $2 billion in trying to help close the digital divide, including providing affordable internet access for those that participate in the government's program. So that's on the connectivity piece. On the ease of use piece, we're working to help provide devices, security, and logistics services. Our vision is that if you are a consumer in your home and need to connect to your clinician, we want to make that as easy to use. And so a good example is if we were managing congestive heart failure, we don't want to send that consumer a box that has to be configured and paired and secured. We want that consumer to be able to open the box and immediately get access to his or her clinician. And so we're working on that as well. So Renee, thanks for having me. Really looking forward to the discussion today.
Great. I can't wait to get into some of these meaty issues given the different perspectives we have. Last but certainly not least, we have a federal agency perspective. Beth, would you introduce yourself and some of the work that's taking place at ONC?
Sure. My name is Elizabeth Myers. I am the Deputy Director of Policy at the Office of the National Coordinator for Health Information Technology. Long name. Basic focus is we're not the innovators here, you all are, but we are the ones who are responsible for trying to establish a foundational platform on which innovation can occur. We've been engaged with FCC and the effort to expand broadband access basically since the HITECH Act, since the American Recovery and Reinvestment Act back in 2009. I personally have actually been involved in the efforts of coordinating across from my prior work at CMS. Some of you who are in the healthcare industry know the term meaningful use and know what that was all about, and trying to really expand access to health information technology for healthcare providers and ensure that we can get to some basic fundamental technology evolution within the healthcare industry, starting from the most basic platform of let's get systems in the hands of healthcare providers, let's get data standardized so that it can actually be captured and shared, and let's think about how we're connecting these systems across platforms to allow for care coordination and patient access to their own health information. We've come a long way since then. We've gotten several foundational principles across, and most recently in the past 2 years, we've been able to put into place regulations that will get a core set of data, so a core set of baseline data elements for care to be universally adopted across systems. The goal for that is actually within the next 9 months to get what is called USCDI, the United States Core Data for Interoperability, to be that baseline care clinical data across systems. And we've also done several pieces that we call interoperability criterion within our program. We've adopted standards for electronic health records and health information technology systems that need to allow for both document-based exchange, so a structured document like a summary of care record or a discharge summary, to move from point to point in an interoperable manner using standards so it can be consumed on the receiving end, but also to leverage application programming interfaces so we can actually start to let the innovators innovate by ensuring that systems are actually doing a standardized platform on which innovators can build. And some really important pieces about what we've done there that hopefully can help to change this dynamic and really think about reducing disparities and getting better access across the entire healthcare industry for all patients, whether they're in rural areas or urban areas or somewhere in between, is to ensure that those technologies aren't just focused on one type of solution. So our criterion, we often think about application programming interfaces and smartphones and apps that you might use to access it that way, but that isn't the only alternative. There are other ways that those particular exchange functionalities and modalities can work and that those standards can work to support the flow of information. And what we think that means for really changing the dynamic is that information that's necessary for care, whether it's through telehealth or an in-person visit or a combination of those types of things, which often is the solution for underserved areas, you can get the data that you need when and where you need it, that patients can get their data in a way that's easy for them to access, in a way that's usable for them so they can have a better way of understanding their care and making more informed decisions and really thinking about how their care decisions can be informed by what their care providers are actually doing with their information. And then also ensuring that when a patient has a visit somewhere, that another care provider, especially for patients that are maybe seeing multiple care providers or maybe particularly mobile, are getting the information that they need that's relevant. And these are essentially important for all sorts of things. We've seen the importance of these over the past 2 years, not only with COVID, but with some of the other healthcare issues that COVID has highlighted, like behavioral health and the opioid epidemic. So that's what I'm here for, is to talk about what we've been doing. It's really a foundation for the much more interesting and fascinating and exciting things that the rest of the panel is here to talk about. Really looking forward to the conversation today, and thank you for inviting us.
Great, phenomenal intros from everybody. You can see the different perspectives all these organizations bring to the table. So I'm going to start off with some questions, and this is for the entire panel, but I'm going to throw it to Dr. Ruth first. As a preliminary question, during the pandemic, we've heard a lot about digital health and emerging health technologies. Can you discuss how these tools are improving health and well-being in this country?
Thanks, Renee. A great question. And we've seen such an amazing array of different technologies, everything from remote patient monitoring and different sensors and wearables to artificial intelligence being applied. But again, back to thinking a bit about the infrastructure and some of the things that underlie that, we haven't been able to deploy this in areas where there have been multiple things lacking. And I'll start again with the whole issue about affordable broadband. Joe had mentioned a statistic that is, I think, oftentimes cited, which is the 2020 FCC report that indicates that 14.5 million Americans do not have access to broadband. Well, this is something that Microsoft has been looking into as well through partners that have done extensive surveys, such as the Pew Institute. And our results and analyses have indicated that that is an underestimate by about 8-fold. It actually is probably closer to 120.4 million individuals across the United States. So I think the first step would be to take a look at really the size of the problem and also the geographies and the localities. Originally, a lot of this was assumed that it was occurring in rural areas. We've seen a significant proportion in urban areas. And what we've realized is that there needs to be more that needs to be done to address this in both rural and urban. Now, some of the other learnings, as Michael had indicated, simply providing access to affordable broadband is a starting point, but digital literacy is the next building block. And as we think about that, we need to find ways to make things more understandable, the ways that people can be able to easily use, accessibility for those that have disabilities and difficulty comprehending the different tools, different language support. I mean, we're talking a whole different way of approaching this to make this much more accessible and inclusive. And then on top of that, healthcare literacy, even understanding what does all this information mean. There's oftentimes you look at the results and it's just very unclear in terms of what exactly is this useful? Is this something that I need to act upon? And when we have those in place, then we can start taking advantage of those amazing technologies that myself and a variety of other organizations have been working on to apply the AI to expand our capabilities. To Dr. Berwick's point, redesign healthcare using infrastructure that now is in place that allows us to be able to think of the care delivery system not so much as an individual visit to a clinician that is now virtualized, but now in which you have an entire care team that has tools to be able to access individuals anytime, multiple times throughout the day and upon demand. That's where the opportunity lies. And we're going to need to start with the building blocks, but then build towards something really magnificent.
Thank you. Thank you very much. Dr. OBrien is a longtime telehealth practitioner. Maybe you can talk a little bit about your experience about how digital health and emerging health technologies are improving health and well-being, particularly in the populations you serve.
Well, thank you for that great question. We've been at it for a very, very long time, and we have been hobbled, honestly, by major policy challenges that all of us, and certainly in the healthcare industry, have faced. COVID has shown us that we can begin to move that giant ship. And academic medical centers, we're giant ships, right? We need to make sure that we're providing high quality care to our patients, that we engage our providers to be able to do it, that we listen to our patients and we understand what their needs are. Some of the things that we have done following COVID-19 include such things as integrating video within our electronic medical record platform. And we chose a technology that would enable us to connect to our patients at the lowest possible bandwidth. And we recognize that we have a patient portal, but not all patients have enrolled in the patient portal. So we chose a technology that would allow us to connect by sending a link to a patient. Now that presupposes that a patient has connectivity, right, in order to be able to support those encounters. So we have to think of all of these things, reimbursement models. I'm really grateful to all the COVID relief funds that have been provided by the federal government, which has enabled us to really transform. Commissioner Carr, I think that he coined the phrase blockbuster to Netflix models. That's what we have hoped to deploy. And as such, where our patients don't have connectivity, we've used FCC funds, such as the COVID-19 telemedicine grants to provide devices to patients, and also the Connected Care pilot program for us to be able to incorporate remote patient monitoring tools into those devices, give them to the patients so they have a form of connectivity, and then enroll them in our patient portal, provide virtual care models. And then it's really important that we use our experiences and our data to transform public policies, right? Because we know the Congressional Budget Office has to score, any bills that are before Congress. So we need to have those outcomes data that demonstrate the efficacy of the work that we have done. So it's been a labor of love for all of us, but moving this big ship is challenging, but we need to bring care to the patient, incorporate their medical home in as often as possible, as much as we can, to improve outcomes and improve access to care. So I say for sure, as Dr. Berwick alluded to, telehealth should be a major role in care redesign, and we need to get providers and systems aligned with that model and that approach. Thank you.
Great. Michael, could you talk a little bit about, you and I have talked offline before about how the Howard University community responded to COVID-19, particularly relying on emerging health technologies. Can you just talk a little bit about what kinds of things you did?
Sure. And as my colleagues probably experience here on the call and throughout the country, the COVID-19 presented an interesting challenge for a healthcare provider. Like many healthcare providers throughout the country, we scaled up a telehealth program in 4 weeks. We went from single-digit adoption to 80% adoption over the course of a 4-week period. It was an extraordinary effort to not only procure a telehealth platform with our EHR provider, which some of our EHR providers were not prepared for this large migration to enhance telehealth in terms of the population and the utilization. So there had to be some tweaks and modifications to make sure that the telehealth platform was robust enough to be able to deliver the level of care that we needed for our patient population. We also had to train our workforce, and particularly our providers. Some of our providers were not as facile with telehealth because they were solely reliant on in-person care, and they were very comfortable with that particular modality. So we had to develop training programs and tutorials to bring our staff and support staff up to the level to be able to engage in a telehealth strategy robustly. And then on the other side, from a patient perspective, I think that there's been a lot of talk about how telehealth has been a critical lifeline, which it has, to be able to provide access to care, to address some of these delayed care issues that were associated with COVID. But what we found is that the same issues that we were talking about surface during that experience. Some of our patients didn't have access to broadband, or if they did have access to broadband, their broadband was insufficient to be able to engage in a robust telehealth encounter. Some of the data, which is consistent with our experience, shows that our patient population, it happens to be some portion of low income, disproportionately use audio calls versus video calls to be able to engage in a telehealth encounter. And we know a video encounter is more efficacious than an audio encounter. Then we were also relying on self-reported data. So we were relying on patients that have limited healthcare knowledge to report back to the provider on their blood pressure, on their different types of biometrics to be able to engage in a engaging conversation with a provider, which the data in some instances was very unreliable. And you were relying on an untrained healthcare professional to have a conversation with a healthcare professional about maybe a chronic disease or even a prevented illness. So we noticed a number of things that remote patient monitoring is key. To be able to have connected devices that are reporting data in real time, that physicians are relying on that type of data as opposed to self-reported data. That data is a little bit more reliable in terms of being able to prescribe an intervention or a different type of model. And then also the other thing that was really stark is that there was a number of patients that wanted to engage from a telehealth perspective, but they were digitally naive, right? They never really used the internet prior to this experience. So as Joe mentioned, the patient experience was incredibly important. There was a low threshold to be able to participate. If there was some level of friction, they would churn off, and means that they wouldn't use the telehealth modality and they would essentially delay care. And we know that the data around delayed care led to progressive disease progression, also in some instances death, right? Because folks could not connect with the provider. So we were like many providers, we ramped up, but we also recognize that telehealth is a critical modality, but there are other wraparound services and other things to be done to ensure that all communities have fair access and equitable access to telehealth.
Excellent, excellent. Joe or Elizabeth, anything to add on this question about digital health and health technologies and how these tools are improving health and well-being?
Sure, I can jump in with an historic story, and hopefully it sort of sheds some light on where we think we can continue to go if we continue to think about things in the way that Michael is saying, where you're thinking about all of the different barriers, because it's not one, it's multiple barriers that we have to figure out how to address. One of the things that 10 years ago, I did a panel actually with an FCC group about meaningful use and the HR incentive programs and all of these things that were giving incentives to certain types of clinicians and hospitals to buy electronic health record systems, and they had to do certain things for it. One of the things they had to do was exchange records and share information with patients. And they could exclude from that if they didn't have broadband access in their area up to a certain amount. And we went through these exercises with FCC of trying to figure out how to implement this, because it was one of the things that the law wanted us to take into account. And it was everything from, you can't do this at a county level because the road where broadband goes up to the end of the road and my facility is 5 feet past it and we don't have that access because it's a fiber optic network and it's not providing it to us. So a healthcare provider literally at the end of the road in that county couldn't actually get onto that system without paying exorbitant amounts of money to build it themselves. So these were the types of nuances that we were trying to figure out. You had to figure out how to, you have an EHR now, but you can't connect it to the internet. So what are we supposed to be able to do there? And it's come a long way since then, and there's been a lot of progress since then. But what we're still seeing is that there are multiple barriers that are in the way. And some of those barriers aren't just about getting the device in the hands of the patient or getting the device in the hands of the provider or whether they can connect to the internet. Then what happens once you've done that? So on the point about remote monitoring and about getting accurate data, and that the care provider might be at a completely different location, not at their medical care home, that's actually doing the telehealth visit, if we're talking about something like that, is that we need to figure out how to connect all of these data sources, and we need to figure out how to make them be more nimble so that you don't have to have heavy infrastructure, huge, massive systems to be able to be nimble. You need to be able to think about cloud-based solutions and think about data standards that connect these pieces. So those are some of the things that we are in particular focused on. And the reason that we're focused on them is for exactly that reason. If we can get sort of a nationwide mesh that makes the data move across the country, even if it starts out in one system versus another. We know during COVID, there were cross-state agreements to do telehealth visits. So someone in Pennsylvania might be seeing a doctor in Wisconsin. How can we get these things to connect? So the doctor in Wisconsin has the data, the patient has the data, and the doctor in Pennsylvania has the data, no matter what their systems are. So that's sort of what we're focused on. So some of these other solutions or some of these innovations around how we think about the people part of it. How do we get a care provider at home and community-based services into the person's house to help them figure out how to use their device and how to connect their remote monitoring technologies? You can't solve those if they can't talk to each other in the first place. So that's what we're focused on. But the rest of this is all like, we want to help make sure that it can be built. So that's what we try and think about is what is the floor that you need to be able to build these things on top of. And I think that what we're hearing is there's still a lot of different pieces that need to be figured out there. So I'm interested in hearing more about what we can do to try and make that floor more stable.
Joe, anything to add on this question?
Yeah, so I mentioned earlier, we're working with a lot of different startup companies, and I just thought I'd share a couple examples of some really neat startup technologies, because I do believe it's an interesting challenge that we're all trying to solve from all different perspectives too, right? We're trying to figure out how do you go from a traditional space of in-hospital care, and how do you take that beyond the four walls of the hospital? And so the providers obviously are front and center. You have technology companies like us and Microsoft here. A lot of what's going to continue to be presented to us as opportunity are these really innovative companies that start with just a few people and an idea. And so we're trying to seek them out at AT&T and figure out how we can work with them to bring their solutions to market and provide that connectivity piece, which is essential in order to make it all work. So just a couple of examples. We recently launched with a really innovative company, the world's first connected pulse oximeter. And so, as you all know, if you went to a retail pharmacy, you could get a pulse ox, but it's likely going to be Bluetooth, and you're going to have to download an app, and you're going to have to set it up and configure it. Now you're going to have the data and figure out how to get it to your clinician. This is, you open it up, put it on your finger, and it just works because it's IoT and cellular connected. So that's just kind of the concept that we continue to look at these technologies. Another one that we recently worked with is a under the mattress pad that gets some vital information and can sense movements with the consumer not even having to think about it. And again, that's right out of the box. You open it up, you turn it on, power it on, it's connected. You don't have to figure that out. You don't have to pair it to Wi-Fi, and you put it under the mattress. And I think you're going to see more and more technologies like that, where the consumer doesn't have to configure it, doesn't even remember that it's there. And now, whether it's aging in place or somebody with a chronic condition, being able to get that information back to the clinician. We're also working with a number of different platform providers that are making really neat remote patient monitoring platforms, and they're tackling it in different ways. And so I think it's neat to see where that's going. It's also going to be neat to see how AI starts to get involved in that continuum of care, because I feel for the providers, and we hear this all the time. Providers say, hey, it's great that you can shove all this data to me, but it's just too much. So how do we work with AI to figure out how machines can do a lot of that initial interaction and triaging, and only until it gets to an escalated case does it actually go to a nurse or a care coordinator or somebody like that. So encouraged by the innovation that's taking place. All that being said, as everybody else has said, how do we get it not only to those that have the resources to afford the care, but how do we then drive the technology to those that are under-resourced?
Yeah, that's a great segue. I'm coming back to you, Dr. Urbana. Before I ask my question, Some of you have already figured this out. You're posing questions in the Q&A. I promise I'll try to get to as many as I can during this discussion. But given what Joe said about all this innovation, from your perspective as a provider and running a phenomenal telemedicine program, what do you see as the current opportunities and concerns about the increasing reliance on technology-enabled solutions powered by connectivity, particularly as regarding vulnerable or underserved communities?
Great question, really, Renee. From our perspective, where does the data go? Who manages that data? How do we integrate it into the patient record? How do we close the loop back to the patient? All of these are important considerations. And I want to also add, currently, we still have so many challenges in terms of the 1834M restrictions, many of which were waived in the waivers that enabled us to reach urban populations who are just as vulnerable as some of our rural and underserved. We need to change that paradigm as quickly as possible, because for health systems to invest, for providers to provide these services, there needs to be a payment mechanism and a reimbursement mechanism that will enable that to continue. We've created some new models, including with community paramedics that will be connected virtually to go to the home of the patient, especially those patients who utilize the ED as their primary care provider. How can we better their outcomes? So a lot of this is that we have to use our research to provide the data to the policymakers that will transform ultimate public policy that will enable us then to continue these models of care. Again, it's care redesign. But today, here and now, we still need relief, because to invest in these systems, our providers need to have a mechanism by which coverage works. So I don't mean to be a naysayer in any way, shape, or form, but it is a challenge. And of course, we do, as Michael said, we need to train our providers in these new paradigms of healthcare. And it is team-based care, and we need to be able to have everybody connected. So kind of a glom back at you, but it's sort of a vicious cycle. We need to break that vicious cycle. I will also add that our Medicaid agency provided some pretty amazing information to some of the congressional committees that showed, following COVID-19, where they massively scaled telemedicine coverage in Virginia anyway, that it was the telemedicine services were not additive. They were in lieu of some of the in-person services. So total cost of care did not increase. And Medicaid has taken that to say, yes, we support expansions in remote patient monitoring. So again, data is critical to change and inform public policy.
Yeah, I think great example of how innovation is tied to policy in healthcare. Sometimes we forget how different this sector actually is. Something that both you and Michael brought up, and Michael, I'm going to turn to you. When I hear the words broadband and connectivity, it usually leads me to think about rural America and rural areas of the country. And I think you touched on this a little bit in some of your remarks, but can you talk about why these challenges are just as critical in urban areas?
Certainly. And it's very interesting, your question, because it also highlights this notion around sometimes when you think about rural America and ample access to healthy foods and vegetables, you would think that individuals that live in rural America would be healthier from a disease burden perspective. In terms of broadband access in urban and rural America, folks, to your point, often gravitate towards rural America is underserved from a broadband perspective. And in fact, if you look at the data, I think the most recent Pew study talks specifically to the urban and rural context. And it talks about how many individuals in the urban area actually might have access, but have poor adoption, right? And so they don't actually have a broadband subscription. So where they might have access, folks are not connected. And that number is higher than rural Americans that are connected or that are disconnected. So it's really interesting when you think about it from that construct. And a couple things that we've seen in practice anecdotally. One is cost, obviously, is an issue. The affordability of broadband is a reason why folks are not connected. A reliance on the mobile phone to be able to query the internet. But as we all know, all mobile phones are not created equal. And if you don't have a robust data plan It limits your ability to be able to participate in a meaningful healthcare experience. And then the other piece is around having hardware available in the home to be able to access broadband. So laptop, tablet, et cetera. And those things sometimes are cost prohibitive for individuals that reside in low income or medically underserved communities in urban environments throughout the country. So what we have started to do is to talk about evidence and correlating clinical outcomes with evidence of using technology and broadband. And we've been doing it through our 1867 Health Innovations Project and working with innovative startups throughout the country as well as internationally, and looking at how we can design models supported by technology to be able to pilot them in a real dynamic clinical setting based on clinical metrics that align with some of our payers, as well as some quality of life factors. And we pilot the technologies in the model to determine whether they are efficacious or not. We use that data to support a business case with the payer to determine whether or not they would reimburse the technology and the model to create additional access. Because I think the only way that we're going to be able to compel folks to think about this, not only in a rural construct, but holistically, is to think about the proof benefits of using technology to be able to improve healthcare access, outcomes, affordability, and most importantly, the patient experience.
I'm going to turn to some of the questions in the Q&A a little bit. And Joe, when you were talking about the pulse ox, you used the term IoT. For those who don't know, can you just quickly explain what you meant by IoT?
Yeah, absolutely. Sorry about that. Internet of Things. So just think about really, really low data connectivity over cellular. And the benefits of it is a lot of times this connectivity is very, very inexpensive. And so if I just want to be able to send something like my blood oxygen levels as an example, that would be something you could use. It's low power, low cost, really low bandwidth kind of connectivity that tends to penetrate really well also into rural areas, into urban areas, into buildings as an example. So we do believe there's going to be some opportunity there.
Excellent, excellent. Now let's talk a little bit about the future. And Dr. Ru, I'm going to turn to you. Often when we discuss connectivity in health, and we've done it today too, people tend to think mostly about healthcare delivery, particularly when it comes to issues like telehealth services. Could you share with us from your perspective, where you sit at Microsoft, where healthcare is going in the short, mid, maybe 5 years down the road in terms of digital innovation, and why and how connectivity is going to be critical beyond just telehealth?
Let's start with where we're at today. A large part of where we're at is we have an ability to do a video conference call. We have an ability to capture data, whether it's on episodic data or continuous data, and all that information is fed into an area that can be secured and then potentially assessed. But there are challenges that we have to look at. If we want to increase adoption, and there's also opportunities. In terms of challenges, Joe touched on one of them. There's just too much data, and it does not make sense for clinicians to be able to be the arbiter of all that information and trying to figure out what's relevant, what's not. It sort of reminds me of, we've turned the fire hydrant, so we now have access to water, but what we need is now a faucet. And we need the tools and the ability to understand how to determine what is the appropriate amount at different times. So advanced analytics can help us. Artificial intelligence can help us synthesize all this information, make it actionable, allow us to be much more predictive. Those are essential tools that are under development and will be critical as we think ahead. Second thing is there's still clinical workflow issues. A clinician at the end of the day is still going to have to document and put that into the electronic health record. You've just added another way for them to be able to do this. But what we now have, because this is in a digital environment, an opportunity to be able to apply AI, specifically ambient clinical intelligence, to be able to capture that conversation, convert that from voice to text, understand the actual context of what we're talking about, map it on the back end to medical terminologies, and then organize that into a clinical note that can be integrated into the medical record. It's already being done today, saves clinicians about 50% or more of their time entering orders, entering documentation into the electronic health record. These type of technologies will be essential as we start thinking ahead about how to increase adoption. Now, because this terminologies, this conversation has been now understandable by the computer, we then have an opportunity to apply clinical decision support and be able to then push this into other arenas and improve care coordination around that. So just a tremendous amount of opportunities as we think about that. And the third is an area that we are excited to explore because there are new opportunities that can arise when we think about what's possible digitally. If I were to have a conversation with a patient, I'm just looking at the individual's face. I have no idea what's going on with the environment around them. Perhaps there's an IV that is out or in, red and inflamed. Perhaps there's something on the ground where the rug is perhaps a fall risk. These are all things that oftentimes would be relevant if I were right there. Well, with some of the digital technologies, in particular mixed reality, we have an opportunity where an individual in the room could put the headset on, and it gives us a point of view that we don't have today with virtual care. This is also being done today. The NHS, the National Health Services, has adopted and is starting to use in certain areas, in particular in the Kendall care homes, an ability for nurses in the nursing home to be able to wear these headsets and provide a virtual care visit where a GP on the other end is now being able to assess the entire room and be able to go into areas that perhaps may not have been possible with a typical virtual visit. So we have so many opportunities, areas that we can optimize and explore beyond, and central to all of that will be data and artificial intelligence.
Yeah, and when you use the term artificial intelligence, Dr. Rue, could you just quickly explain what you mean?
It really is just an opportunity to be able to bring disparate and vast amounts of data together so that we can process it in ways that an individual would be able to do, but at much faster speeds and with higher reliability. So oftentimes the things that we're talking about automating, a human is currently doing or a human should be doing. And what we want to do is we want to find ways that the computer can help those clinicians and patients be able to do things much better, faster. And that's relevant because oftentimes we find out much later after the fact when somebody's looked through the medical records or looked through all the data and identified, boy, that would have been sure helpful if I knew that when I was talking to the patient at that time. That's what can be very helpful because it allows us to be able to accelerate the learning process and present that information when clinicians and patients need it.
Now, sticking with that theme of that, looking sort of into the future, Joe, obviously AT&T is a non-traditional player in healthcare. So what do companies like yours foresee in the future, and what role are you going to play in our health and educational systems as we continue this digital transformation of our healthcare system?
It breaks my heart to hear you say that, Renee. I definitely want people to walk away from this with a sense. But seriously, we do have a responsibility at AT&T. And I think large companies in general do, because there still are gaps in care and challenges. So we see healthcare and the digital divide in general as areas where we absolutely need to be very purposeful about making a difference. A couple things come to mind when you ask the question. I think one is you should expect companies like AT&T and carriers to continue to invest in the network. So really great comments. A lot of times, Michael, I heard you say that when people think about gaps in connectivity, you think about that rural area up in the mountains, and carriers have to continue to work to figure out how to get coverage everywhere. But there's also that challenge in rural areas just in terms of coverage. And so companies like AT&T need to continue to invest and make that coverage available for sure. I think the other thing is you just can't watch what's going on in the world right now and not think about the threat to cybersecurity and to patient information. And so it's going to be important for the technology companies and the carriers to come together and figure out how do we secure data and how do we try to minimize the cyber threats. I read a stat recently that in the first half of last year, the number of compromised health institutions was up like almost 30%. And about 22 million Americans during that period of time had some personal health compromised. And so how does an AT&T, a carrier, how do these big technology companies help secure that information? And then I think lastly, just the ability then to say, we want to help the under-resourced, one, by providing a low-cost broadband internet. I mentioned that earlier, but the government has come out with a program for reduced internet access for those that qualify. And AT&T came out with a plan that's discounted as well. So those individuals actually could get free internet, which is awesome. I can't think of any time we've had that before. So I think that's a big deal. The other thing is there's also a bunch of new opportunities for municipalities now to get reimbursed for investment into furthering broadband deployments. And so I know there were some questions about, gaps in areas and what about neighborhoods. I think you're going to see some partnering from the carriers and the municipalities now to go figure out, how do I get coverage? Because I think all of us, I'm sure, have experienced or lived somewhere where the coverage just wasn't adequate. And so when that happens, a lot of things break down, especially in today's world with the connected home. And so we're going to continue to partner with municipalities there.
Wow, a bright future indeed. That's awesome. So, Elizabeth.
I just want to add one thing, that it really behooves us as providers to make sure we're thoughtful about our processes so that we don't consume our patients' data plans with patients on hold waiting to be seen. It's the whole ecosystem. We have to be thoughtful because these patients may not be able to afford unlimited data plans. And so accordingly, those processes are important considerations for us as we provide these services.
No, Dr. OBrien, I think that's a great point. I think what we're starting to see, which we didn't see a lot of, we haven't seen a lot of historically, is different sectors talking to each other. And this panel is a great example of that. So Elizabeth, back to you a little bit. You talked a little bit about what ONC is doing. What can the innovation community do, as well as other agencies within the federal government that are developing broadband policies? What can we do to support ONC in its work now and where you think healthcare is headed in the future?
Sure. And I think this actually relates to something that Karen mentioned and something that Michael was mentioning as well. And, the title of this session includes SDOH, right? So we're talking about social determinants of health. And the idea that broadband needs to be considered as a social determinant of health, that connectivity and technology access is a social determinant of health, just like food insecurity, transportation access, these housing security, these types of things are all interconnected and they're often co-occurring. So one of the things that we've been looking at a lot is thinking about health equity by design. So thinking about how we are ensuring that there's a saying that, and I'm going to get the saying wrong, but if you aren't being deliberate in the beginning about underserved population, what you're doing is actually exacerbating disparity. It doesn't matter how well-intended it is. If it isn't deliberately trying to address disparities, it is exacerbating it. And so one of the things that we think about when we think about social determinants of health and how that data can move, so you talk about closed loop referrals, and you talk about how a clinician could be using up someone's time, or a clinician could be referring someone for telehealth when they don't have access to telehealth, right? And we talk about rural areas where people have to drive 2 hours to get to a facility. Well, in an urban area where you don't have a car and it's 6 miles away, that is just as much of a challenge. So transportation insecurity, housing insecurity, and technology insecurity are all interconnected. So we've been particularly looking at a couple of areas that think about healthcare in the big picture of this type of consideration, and how we need to think about things like home and community-based services, community benefit organizations, and what we call closed loop referrals. Those would be my top priorities when we think about healthcare and social determinants of health and broadband. Thinking about how to innovate so that we're talking about how we care for the whole person, because healthcare is just one aspect of what underserved communities aren't getting because they don't have broadband access. I'm going to plug in an example, but I won't tell you where it is because it was actually a family member of mine that was engaged in this. But you talk about individual communities, and what we need to take are some of these really innovative things that are happening in individual communities and figure out how they can happen sort of automatically on a national scale. I know of a particular urban area that a hospital and the schools paired up at the beginning of COVID. And when they gave out laptops to kids so that they could go to school digitally, they did family trainings on laptops for healthcare. So that the facilities, the healthcare facilities were actually sending nurses along with the teams, and it took forever and it took a lot of money and dedication, but they made that happen by doing that paired work. And they have a large population that is English as a second language there. So this was particularly useful for that particular aspect. So that's a community-driven focus. But if we think about technology, technology can facilitate that being easier to do. Technology can tell a clinician, this person has transportation insecurity and connectivity insecurity, so maybe we need to figure out if there's a community-based service that can help them to get to care, to get to clinical care, or the other way around, that a community-based organization that knows that someone is involved or enrolled in certain programs is doing reduced school lunches for their children, whatever it is, that they know that that person might not actually have access to healthcare. So how are they going to get a telehealth visit if they don't have a care provider to refer them to one? So it's about thinking about how technology connects these dots and offers up a solution to David's point of not just getting all the data, but what can the data tell us to do? What can the data tell us to act on? How can we research the impact of that so we can continually improve how these interventions work? If we know what you all can focus on there, we can help to make sure that the tools that you need to do that are included in the basic regulatory functionality that we require.
Great, fantastic. I'll be honest, I didn't know ONC was this heavily involved in this area, so this has been very educational for me, and I'm sure for members of our audience. Now, we're running short on time, so just sort of last question, and if everybody could be brief so we can get people to lunch on time. So we've talked a little bit about how the way people live, learn, work, that affect a wide range of health and functioning, quality of life outcomes continue to evolve. What are your primary concerns about this future in ensuring that people have access to high quality care? All people have access to high quality care. We'll start with Dr. OBrien, and again, we have about 3 minutes, so brief would be great.
If we want to start with inclusion, it's about making that extra effort to be able to make sure that the underserved, the vulnerable, the disadvantaged are not being left behind. And we saw during the pandemic that there are people being left behind because we hadn't addressed these issues in the past. And so that's going to require extra time and resources. It means that we have to prioritize inclusion in our design for technology, in our rollout of programs, and also in our budgeting. And so infrastructure is a critical part. Broadband is now a part of critical infrastructure to support inclusion as well as healthcare. The second is around people. Right now, there are many individuals that are not only critical as part of the care delivery system, but are not necessarily being met in terms of digital support. Caregivers, community health workers, social workers, case managers. These are individuals who work for organizations that need funding, that need the tools to be able to better manage their care. And these are digital tools that will allow us to be able to become much more efficient. And the last is around scale. We need to have infrastructure in place. And a lot of the pandemic learnings have related to the fact that we work in silos and we have lack of infrastructure on the public health side, lack of interoperability between the different systems, and also the fact that we don't have consumers yet fully empowered with their healthcare. These are all initiatives that I know that the ONC and others are actively working on, but we need to continue to push towards that, because with that, it'll allow us to be able to then leverage the entire power of the organizations and the people that they serve. And that's something that will allow us to be able to move forward.
Phenomenal comments. And I know we're running short on time, but we'll go an extra 5 minutes if the panels will allow, so everybody can comment on this, because I think this is an incredibly important question. Dr. OBrien.
Sure. So, and what David's comment is completely appropriate. I completely agree with him. I would say also, since we are pretty much agreed that telehealth should be a major component of care redesign, that we get all the federal agencies working together to do strategic planning moving forward and to work with the states, because states bear major responsibilities in care design and care delivery for Medicaid populations, for insurance redesign, et cetera. So getting people together to do strategic planning would be my major goal and desire going forward.
Michael?
Similar to my colleagues, I think we have an amazing opportunity to think about the 21st century from a digitally inclusive perspective. And it's a matter of, in my opinion, of emergency preparedness, right? We've seen communities throughout the pandemic that didn't have access to broadband, so they couldn't sign up for a COVID-19 test. Individuals that didn't have access to broadband or platforms that spoke their language or accommodated disabilities of individuals throughout the US to sign up for COVID-19 vaccine. What we found is that if you're not connected, then it's hard for us to reach you. And I like to say, if you're not connected, you're not counted, right? So we have to figure out how we keep the American public connected and think through what that strategy would look like, because it's a matter of emergency preparedness, in my opinion. And the only way that we can realize a transformed 21st century healthcare system is that if we're thinking about broadband from the basis, also looking at care delivery and different types of models to treat different types of communities. So it's not a one size fits all. We really have to be very prescriptive and intentional how we treat different communities throughout the country. And then we have to make sure that we have the workforce and infrastructure in place to support this transition. And last but not least, the White House Office of Science and Technology recently has talked about this community connected initiative. And I believe our innovation program is very much aligned with that. In order for us to really address some of these social determinants of health and healthcare disparities, the principal way we probably could do that is through technology. So if people are connected, they're optimized, they have literacy and support, because support is an area we haven't talked about, folks will be able to really be able to use these technologies both on the provider as well as patient side to optimize their health and well-being.
Joe?
I'll approach it from the consumer angle. These are all great comments, and I'll just add on. My mother's been going through a battle with cancer, and she's getting phenomenal care. It's all in the hospital or in the medical facility. So it kind of makes me wonder how much of this could be actually done at home, and how do we all work together from the providers and the clinicians themselves to be open to change. It's change for everybody. It's change for the consumer, but it's also change for the clinician and for the entire system. But how do we work together with technology companies, with startups and innovators, and then certainly with organizations like the ONC and the FCC to really change the way we provide care in the United States for the benefit of all consumers, those that are under-resourced as well, and also to provide better outcomes in ones where people can be where they're more comfortable, oftentimes in their homes. So I think it's an opportunity. I think it's a big task too. But this is a good example of us all coming together to tackle these together. I think that's ultimately what's going to have to happen in order to see this shift really take place in the United States.
Great comments. Elizabeth, to round us out.
Sure. So I think I'm going to make a fairly specific ask, actually, to get at what everyone's talking about here with infrastructure. So what happens over and over again is that there is a mandate or a government program, and we all want to do something. We want to solve opioid epidemic, or we want to make lab reporting work so that COVID test labs actually report all back to the same place and we can figure out what the heck's going on. And over again, those funding packages, whether it's from Congress or from the administration or wherever it is to the agency, don't have infrastructure built in the beginning. And they don't have this conversation about equity by design infrastructure built in from the beginning. So if you get a separate infrastructure package through that says, let's expand broadband, that's great. And then you have to go back to that and think about, oh, we're going to put healthcare in there, and we're going to put education in there, and we're going to put all these other things in there. But then when you get the specific healthcare or education thing, it doesn't include the infrastructure, and it doesn't consider connectivity and broadband and the technology that both the provider and the patient need, right? Because we are also talking about providers who don't have technology either. Behavioral health providers, home community service providers, providers in underserved areas that weren't part of meaningful use 10 years ago. So it's all connected to this concept of infrastructure and being able to have technology support healthcare. In order to do that, every single one of those packages needs to include the funding and the considerations for it. So when you talk to leaders in government, when you talk to your state leaders in government, when you talk to your congressman, remember that that is a key piece that needs to always be considered. We need to always put infrastructure design for equity and disparity reduction into the package, no matter whether the goal of it is reducing some particular OUD issue or addressing child and maternal health or whatever it is. It needs to include that key piece of infrastructure as a part of it.
Excellent. I want to thank the panel for an incredibly informative and interesting hour. Fortunately, we're up to time. I also want to thank the audience for providing a lot of interesting Q&As. Unfortunately, because of the fulsome discussion we were having, we couldn't get to a lot of questions. But again, thank you very much, audience. Thank you very much, panel, and hope you have a good rest of the week. Thank you.
So thanks, Renee.
Thank you.
Thank you very much.
Thank you all.
Thank you, Renee.
Thank you. We're now going to take a break for lunch until 1:30 p.m. Eastern Standard Time. We would ask that you come back for our start of our next panel, panel 3. So thank you all.